We would like to thank Biogen and Scholar Rock for their generous support of this symposium.
We really want to encourage those exercises to be implemented into one's activities of daily living that are highly specialized and individual to the patient or person with spinal muscular atrophy, and adapt the program to be able to meet their current functional status, as well as be age appropriate to allow for compliance and ongoing performance. We want to keep it interesting. So exercise can help you maintain or improve strength, balance, activities of daily living, overall function, range of motion, endurance, participation level at school, during social events, and at work. Exercise interventions for individuals with spinal muscular atrophy should be based on the standard of care guidelines for SMA. We want to make sure that we reference these guidelines because individuals with SMA require specific considerations regarding overexertion and exercise-induced fatigue, as well as safety concerns. We want to work within the available range of motion and allow for compensations as long as we're making good alignment choices that will still allow people with scoliosis or other spinal deformities to participate. We also want to make sure that we are providing a methodical progression of the exercise program for all individuals to participate safely. See, there we go. So why exercise? Why do we want to perform it, and what impact does it have on our function and strength for those with spinal muscular atrophy? Well, exercise has the potential to reverse effects of inactivity and weakness from lack of use. It helps improve remaining muscle function. It can impede the development of negative musculoskeletal changes, such as contractures from ongoing loss of range of motion. And also the principle of neuroprotection, there is evidence with reduced motor neuron death. But more research is required to determine standardized exercise interventions for individuals with SMA. Truly, most of the evidence we have today do not meet a high-level standard that is required and looked for when we are searching for quality research articles to help support and determine optimal exercise prescription. We still have a lot of work to do in this area to make appropriate and safe recommendations. That's my plug for more research. In a study by Jessica Trankel and her colleagues in 2021, they sent out surveys to many practicing pediatric physical therapists across the United States. And they found that the biggest facilitators to having people implement and stay compliant with exercise recommendations was parent and caregiver support and understanding, as well as proper education to the patient on what the exercises they would be performing, education and increased awareness of potential effects of PT and exercise therapy, and the ability to have access to effective medical and disease-modifying treatments. Barriers to implementation and compliance with exercise recommendations were time to complete the prescribed program, the lack of financial resources, whether that be getting to and from a gym, attending a formal physical therapy program to assist you in creating this individualized program, access to facilities or specialized gym and or equipment, your medical status, and transportation. The standard of care guidelines for therapy and rehabilitation will be kind of the framework for all my recommendations made today. The updated consensus statement was published in 2018 by Mercury and colleagues, and it was resulted from an extensive literature review and multiple rounds of Delphi surveys and a working group of experts in the field of SMA. All the results were compiled and subdivided into using functional classifications from the original consensus statement. And I plan on carrying forward those functional classifications in this lecture just to simplify things into the 3 categories of non-sitters, sitters, and walkers. So what are these guidelines? The standard of care guidelines for exercise and strengthening are listed here on this slide. The frequency, we would like to see a minimum of 2 to 3 times a week for strengthening, and optimal frequency would be greater than 3 times a week. The length of this strengthening episode would be a minimum of less than or equal to 15 minutes with recovery time included, and optimal would be greater than 15 minutes. For aerobic exercise, the frequency recommended is 2 to 3 times a week at minimum, and greater than 5 times a week would be optimal. The duration would be up to 30 minutes at a minimum and greater than 30 minutes for optimal performance. Granted, these are guidelines. No one is expected to start out at this frequency or duration when you are first starting a program. So these are something that will assist you in working towards a goal or having an idea of what the suggested guideline or goal is set by a panel of experts when they developed these. So do not be discouraged if you think this looks like a lot or you don't understand when you would be able to possibly fit this in. We're going to go through some examples later on in this lecture. But keep in mind, we're going to try and focus on exercise being encouraged, incorporated into your daily living, and those activities that you have to do every single day. And again, a plug to make it age appropriate and interesting. The standard of care guidelines for stretching and range of motion. Basically, the goal or aims of stretching and range of motion are to help maintain joint mobility and flexibility, promote function, prevention and or management of contractures. So modalities for stretching and range of motion are considered active assisted stretching or orthoses, standing frames, and prolonged positioning, such as serial casting is an example of different modalities that can aid in your stretching routine. The standard of care guidelines set a frequency of 3 to 5 times a week at minimum and 5 to 7 times a week for optimum. The duration should be greater than 60 minutes to improve length. They'll recommend holding an end range for greater than 30 seconds for maintenance. So many people already implement the use of static positioning orthoses or braces, such as AFOs, neomobilizers, and many of these are worn overnight by individuals with SMA, especially when they are growing, to help prevent further contracture development, as well as hopefully maintain the current range, which is hopefully a more positive than negative with an existing contracture. So the standard of care guidelines for supported standing are a duration of less than or equal to 60 minutes as optimal at a frequency of 3 to 5 times a week minimum, or 5 to 7 times a week optimal. Supported standing helps stretch the lower extremities. It can improve or allow for upright participation at eye level with their peers and improve posture as well as bone health. We all know that supported standing also has positive benefits for digestion and respiratory status. So our non-sitters, some of the exercise recommendations for individuals who are unable to sit up independently can be aquatic therapy with proper head and neck support. Making sure that we have some mobile arm supports can also assist us in some of our exercises that will be demonstrated later on in the lecture. This helps deliver safe movement in a gravity eliminated manner, and can multiple things such as bungee cords or supportive bands or slings can be used to help implement these supports. Stretching, orthoses and splints for upper and lower limbs, such as knee immobilizers, AFOs, as well as TLSOs, cervical bracing to help provide support. Active assisted and passive techniques, again, go along with some of the braces that I just mentioned, supported standing frames, and thoracic and cervical bracing. There we go. Considerations for varying degrees of functional ability when we discuss non-sitters. So we want to build up a tolerance to any of the specific positions, such as upright standing in a supported standing frame. We also want to make sure that we build up that tolerance with the specific type of equipment you are going to use, whether that is a standing frame, wearing a TLSO and increasing the hours gradually. Building up tolerance for those who have already present contractures by implementing prone positioning, which is laying down on your belly again to help reduce and elongate the shortened muscle groups. We also want to really evaluate responses to treatment. So we're especially going to be cognizant of monitoring the heart rate. We are going to help keep track of respiratory rate. This is where we can start to utilize perceived exertion scales. And we want to watch for compensations of lack in quality of the movement or how they are positioned. And we also, if possible, would like to monitor oxygen saturation. So we can do this now more readily with over-the-counter pulse oximeters. So some exercise options for sitters. This can range from a variety of activities depending on your likes and preferences. But some of the things that we can be looking at for our sitting population is aquatic therapy, resistance training, wheelchair sports, and community-based activities for a broad picture. Some examples of aerobic exercise could be a seated elliptical, an aquatic therapy program, or just recreational swimming. These can also be seated ergometers for the upper extremities and lower extremities. Community activities for adaptive yoga and dance opportunities, as well as strengthening for early resistance training of upper body and core muscles. We also want to remember that mobility interventions, such as gait training with the use of HKFOs, KFOs, loft-strand crutches, or posterior walkers, can all be used to assist with efforts to enhance and improve ambulation, as well as you can achieve an aerobic capacity or consider it to be an aerobic event by trying to do manual propulsion of a wheelchair, keeping in mind how long and how far the distance you can travel, and understanding your perceived exertion level is another way you could implement daily aerobic activity into your schedule just by using your mobility devices. So considerations for this group of sitters. We definitely want to make note of contractures and positioning. We want to modify exercises based on the available range of motion, and we want to determine the best position for maximal range of motion during arm or leg bike exercises. We want to make sure that we're understanding and acknowledging any scoliosis or spinal deformity. We want to make sure to encourage optimal support through bracing, such as a TLSO or Benic, just as examples. We also want to modify the position to support the selected exercise. Exercise should also be integrated into the ADLs and mobility tasks. We want to select exercises that help promote and enhance the quality of life. So here are some examples. Here are some examples of exercise for walkers. We can implement swimming, upper and lower extremity ergometers, walking, yoga, Pilates, interactive video games, wheelchair sports, hippotherapy. Well, some of these exercises, all alternative exercises and not so traditional, such as hippotherapy or vibration-based therapy. That does not mean just because they're labeled as other alternative options to therapy that these aren't as beneficial or enjoyable for individuals. So considerations for varying degrees of functional ability with our walking group. We want to make sure we pay attention to endurance and fatigue. We want to include an active warm-up and a cool-down period. We want to avoid too much too soon. We want to make sure there's a systematic approach to increasing our aerobic endurance capacity. We also want to consider safety. We want to make sure to assess impaired balance and risk for falls prior to initiating any exercise. We can also recommend the use of mobility devices for additional support and safety during exercises. Mobility devices and supports can help increase the likelihood of building confidence as well as security when performing those exercises, and they can be factored into aerobic capacity monitoring. We also want to make exercise a lifestyle habit. So we want to choose activities you enjoy. We want to incorporate them into daily tasks such as activities of daily living and mobility. So we don't want to make it seem like after a very long day that now we have to do something specific for a set amount of time and call that exercise. We should really look and acknowledge the whole day and schedule for all functional capabilities and classifications of what factors in and counts as exercise. So some helpful information prior to implementing a strengthening program is needed. So strengthening exercise, basic definitions. Repetitions, they're one movement or exercise completed through your available range. A set is a group of multiple repetitions in a row. The frequency is the number of times you exercise per week. The weight is the amount of weight or resistance you are lifting. And stability comes from and enhances balance and safety in a standing or seated position, so your chair or wheelchair. So some exercise aids that can be used during your strengthening program. For equipment, it can be upper limb assisted devices to facilitate active assisted exercise, strengthening, and active range of motion. Suspension straps, gravity neutral orthoses, such as, I'm drawing a blank now. I will think of it. I have it in my head. Suspension straps, it's a brand. Physical therapy can also be used and sought out to develop an individualized home program or adaptive gym. A personal trainer who has specific experience related to working with individuals with SMA is also nice to seek out if you can. It definitely is beneficial for those starting out and who require and would benefit from more guidance in the beginning, to help establish program that is highly individualized, to request a consult to your physical therapist. They can work with you and make sure you're comfortable performing all the exercises, ensure that you are safe, you are executing the program in good form, and you know how to monitor for perceived exertion levels so that you don't overtrain or overexert yourself, resulting in fatigue, burnout, and failure to keep compliance with your exercise program. Modalities are also available to assist with muscle performance, such as massage, stretching techniques, myofascial release. These can all be continued or initiated with the start of an exercise program for strengthening or aerobics. So some adaptive equipment that can help you perform your exercise program with greater ease. A grasping cuff or activity mitts, as seen in the bottom picture with the blue dumbbell. These are good for individuals with poor grip strength or limited hand function. It helps secure your hand on the actual weight or item you are trying to lift so that you do not have to worry that your grip will not hold the weight, or that you might actually drop something and hurt yourself. A wrist cuff can help perform strength exercises by attaching to a resistance bands or cables on weight machines. These are also good for individuals with limited hand function. Stabilizing straps or gait belts assist in achieving proper positioning in the wheelchair or seat, and they can be good for individuals with decreased balance and stability. Adaptive equipment, ankle and wrist weights. They can be used for strength training activities for both upper and lower extremities, and those can be implemented and utilized when deemed appropriate and at the right phase in your exercise training program. Medicine balls, those can be good and used for strengthening as well as ways to increase your heart rate and your aerobic ability. They are for individuals with limited hand function and that can utilize a ball with a textured surface, handles, or straps. Elastic bands or tubing is also a great option. It's low cost, portable, it has varying degrees of resistance. Usually, most of people who have worked with these, they typically go in a color coordinated fashion to light to heavy resistance, and this is something that can be used as part of your progression. To increase resistance, you could also adjust these bands to allow for less slack in the band or move it away from where it is anchored. So these are all easily obtained items that can really benefit you and make your workout more beneficial, safe, and it can optimize your form. So where do we start? So if anyone's starting or wanting to start a strengthening program, we want to make sure that we understand we want to start out with lighter loads when you're beginning a weight training program. We want to achieve adequate and proper alignment. And for this, you can utilize a mirror, or if you have a therapist with you, they can help ensure that you understand what proper alignment and good form or posture feels like, as well as looks like as you execute the specific maneuver. You want to lift weights or utilize resistance bands in a slow and controlled manner. You want to exhale with exertion and avoid holding your breath. You want to start with lower repetitions initially, around 8 to 12, and then work up to that recommended 10 to 15 reps. You also want to try and alternate muscle groups. So if you work your upper body one day, you do not want to perform that same area on another consecutive day. By alternating upper and lower body, you minimize the risk for injury, overuse training, and muscle soreness. Before you start any type of exercise program, you want to really focus on the big ticket items, such as standing, transitions, balance, and walking. We want to perform exercises that will help maintain function. We want to limit and manage our fatigue, and we also want to pay special attention to our endurance. We want to also make stretching part of our daily routine. And this could be simple compliance with bracing. As we all know, compliance with bracing is not always so simple, and it is something that can help us provide a prolonged, adequate position at multiple different joints. We also want to obtain physician clearance if needed for ongoing health concerns. Some of those areas could be cardiac, pulmonary, or orthopedic. We want to make sure that we acknowledge any safety considerations particular to the individual with SMA, such as if they are at risk for falls or any osteoporosis or osteopenia that would put them at greater risk for fracture. We want to start slowly and progress the frequency and duration prior to intensity. And we want to always be careful and watch for any compensations in our alignment that would allow for poor posture and eventually any type of injury. So typically we use and rely on FIT principles to help create and guide our exercise program. These principles of how long, how often, how hard, and what kind can be used by you or your therapist, and they will help better develop an individualized exercise program for you. All of these variables can be adjusted as one improves their endurance and aerobic capacity, as well as wants to switch between various exercises. We also want to make sure everyone's familiar with ratings of perceived exertion. This one is the RPE scale, which is on 1 to 10, but there's also the Borg scale, which some of you may have used or heard of, which goes up to from 1 to 20. So for this particular one, I have a preference for the RPE scale just because it's less numbers and a little more easy to remember the categories, for me at least. And exercise is recommended for all individuals with SMA to be anywhere between levels 1 to 4. Obviously, when you're just starting out, we don't want to really go above those areas of perceived exertion. But if you are someone who regularly exercises and are not new to implementing any type of aerobic program, then it's safer for you to monitor your perceived exertion, but actually go up between 5 and 7 level of perceived exertion. So moderate to vigorous activity is always the optimal goal. And for aerobics, we're thinking approximately a goal of 150 minutes a week. So 5 sessions of 30-minute bouts of exercise would suffice to meet that goal. But research has found that it's not always easy for people to make that goal of 150 minutes. And they have found that it was more well received and the ability to meet the recommendation for strength guidelines in the standard of care than the aerobic one. So you might be asking, how do I progress my aerobic sessions? Like I mentioned, you do want to work up to a moderate to vigorous intensity level, but obviously when you're first starting, we're going to start at a lower, more manageable level until our body adjusts and acclimates and is ready for an increased challenge. We also want to be methodical and organized when we increase the parameters of speed, intensity, and duration. We want to make sure that we don't increase all 3 parameters at once and that we do this in a staged and organized manner. How should I progress my strength sessions? So progressive resistive exercises, you can steadily progress the parameters and increase them accordingly in weights, reps, and sets. Remember those definitions in the prior slide that went over and reviewed what a rep and a set and the frequency was. You also can increase frequency and duration before resistance. 2 to 3 sets of 8 to 15 repetitions each, building up to that goal of 15 repetitions. And we want to ensure good form. So we want to watch for compensations and fatigue setting in that would impair or impact our ability to maintain good posture. We wouldn't want to increase the frequency or duration of an exercise or the resistance if we can't complete our current level with good form. You won't be getting the most out of your exercise bout, and you won't be seeing the full benefits that each exercise is trying to address if we use bad form. So a sample workout program. Lots of people wonder, what does this look like? What would be okay for me to start doing that would count as a warm-up or a cool down? Well, active warm-ups can include any unweighted repetitions or active assisted range of motion of the particular body segment you plan on working that day. So for example, toe taps, seated marching, seated twists, shoulder shrugs, shoulder circles, forward and backward direction, bicep curls, and glute squeezes could all be part of an active warm-up. And these are taken from a site that I found that you can purchase different pictures at Pink Oatmeal. I've included the reference at the end, but this gives a good example of different poses that we can do as well for part of our warm-up, or if they are more of a stretch, they could also be used as a cool down where you can do more stretching with sustained holds for the 30 seconds to help with muscle recovery. So some seated stretches that we can opt to do in a regular chair or a wheelchair are provided here. You can see that you can do an overhead stretch. You can do trunk rotation. We can do an overhead stretch where we're addressing your triceps. Opening of the back stretch with palms clasped in front of us, and trunk rotation, arm pull across the body to help ensure that we have adequately warmed up those muscles, or if we hold those stretches, those could be done at the end of our workout. These are some other seated stretches that we can implement for shoulder shrugs, neck stretches, forward bends, and knee to chest. This helps address low back tightness, hip flexor, hamstring tightness, cervical tightness, and shoulder tightness. This is what I previously mentioned, that we were going to show different options for exercises for non-sitters. This is utilizing a frame made of PVC piping that has attached straps or bungee cords to the apparatus to allow for gravity-assisted movement opportunities. And this is really, well, at least this size is ideal for infants and toddlers. But we can adapt different UEU machines for the upper extremity cages that we can put inside our homes, and also make them attached to door hinges that can also assist older adults and adolescents in assisted mobile arm supports. So Some other ideas for what resistive exercises for our walking group can be, and I have pulled illustrations with permission from MDA for an upcoming home guide for exercise for individuals with SMA. So that likely will be released to coming soon, if not during this symposium. But some of the exercise illustrations used here can be used to incorporate resistive shoulder movements. So the top left picture is shoulder blade squeezes. The bottom left is shoulder extension. The top right is shoulder flexion. And the bottom right is an example of shoulder abduction. Now, these examples all utilize a resistive therapeutic band, as illustrated in the prior slides. Ways to progress this movement are to first perform these movements without any type of resistance or band or arm, cuff, or weight. Then we slowly, gradually add in the resistive band at the lowest resistance and work up to the highest resistance, or where you've met, where you cannot continue with meeting the set reps, repetitions for each set. So we also want to make sure that we maintain good form throughout the whole motion. So all of these can follow the principles of starting out with lower reps for 2 to 3 sets and working up to a goal of 2 to 3 sets of 15 reps total. Other images illustrate resistive elbow exercises. So on the left, we have resisted elbow flexion, and on the right, we have elbow extension. These can be performed in standing. They can also be performed seated. You can end up linking an apparatus on top of your door frame to do the elbow extension in seated or standing positions. And you can link the resistive band around your foot in a seated or standing position to provide resistance of elbow flexion or bicep curl. Again, the progression is the same here. You could start with no resistive band, work up to implementing the lightest band, and then work through your progression to the most challenging therapeutic band for you that allows you then to work up to meeting the recommended sets and repetitions for strengthening exercises. Examples of strengthening exercises for the hip. You can perform seated hip flexion or marching in place. This exercise can also be used as a active warm-up. You can also perform sideline clamshells. So one way to progress the clamshells would be to implement a therapeutic resistive band just above your knees that is of adequate resistance and increase the resistance level or the reps or frequency of this exercise as you go. It is absolutely acceptable and encouraged to start out with no resistance band and no weight if you are able to perform these against gravity, as are illustrated in these pictures. There is no need, and you will still get benefits from performing exercises like this and not progressing to a resistive band. Strengthening for the lower extremity and gluteal muscles can be performed with squatting. Some of the safety considerations for this exercise, as many individuals with SMA find this to be a challenging exercise and position, are if you feel that or you have the tendency to have your knees buckle or any type of weakness in the lower extremities where you're not confident, you can perform this squatting exercise in front of a chair. So if your legs happen to buckle or you feel slightly weak and need to sit down, the chair is right behind you as a safety measure. To increase balance and stability and overall safety, you can also hold on to a stable counter or heavy piece of furniture that isn't going anywhere to help provide that extra reassurance and stability. These are pictures of different ankle range of motion exercises. So we have ankle plantar flexion and dorsiflexion in the top left picture. We also have the progression where we are using the TheraBand around the foot, and we can either attach that resistive band to a stable surface, a doorknob, a heavy object that provides counterbalance for us while we perform this. We can also do range of motion at the ankle in an anti-gravity state to help encourage all the different planes of motion at the foot and ankle. These are other examples to help encourage wrist active range of motion and strength, as well as grip strength. So this particular illustration uses a hammer because that provides a certain amount of resistance. But you could also, if you're able to hold on to a small can of cream of mushroom or whatever you have, a soup can that would be at home, that would not impair or create more issues due to the grip and the width of the can, you can use that too at home. It doesn't have to be a hammer. You can also use a simple dumbbell and work up into the resistance that is challenging and supportive to your exercise goals. If grip is a problem, for some individuals, you can start or try a tennis ball. If that doesn't work and that is too hard, or we have contractures that limit this as a possibility, we can also use TheraPutty or soft foam to help depress that and work on grip strength with a more restricted range of motion at the fingers and palms. So there's definitely different options too of resistive putty, resistive bands for the hands and fingers that can be implemented and sought out. An option for core strengthening here is if you are able to get down on hands and knees, you can utilize this motion where you're starting on hands and knees and you're reaching out with one upper extremity and the opposite lower extremity. Your goal here is to try and really keep your abdominals active and maintain as straight of a back posture as you can, and not imagine a dipping where you're letting your core muscles go. You want to also try and keep your head in line with your body and not necessarily strain your neck while doing this if possible. I know that's a common compensation some people utilize when these exercises start to get tough, and it adds additional strain to your neck. So some helpful resources and web pages that you may find that you want other ideas that I came across while creating this lecture were some yoga poses. This was also a wheelchair athlete who worked with the Christopher Reeve Foundation, but it had nice illustrations and descriptions of exercises and poses. There's also what I mentioned, and I showed a little illustration of some of the pictures used from the Pink Oatmeal Shop. My apologies. Hang on one second. Sorry about that. Adaptive exercises and games are seen on this website, and they can help make exercise fun. Again, remember the advice to make exercise fun and age appropriate. This is a site that would really benefit the younger individuals with SMA and those with that are just interested in performing exercise as well. So it's for all ages, those who have functional limitations and those who don't, but it creates games and other options to incorporate exercise, especially for younger ones who won't understand the whole structure and aren't appropriate to have structured sets, reps, and it should be more thought of and incorporated into play. So that's a nice resource to also go to and check out the different things they have available. Another visual that I wanted to show you was the baby gym. We get asked about these PVC homemade apparatuses quite frequently, especially in the inpatient setting when an infant happens to be hospitalized for longer amounts of time and we don't want them to continue to lose strength or endurance. So one of a patient's fathers found this and posted it on the internet. So we thought it was a nice visual. He provides a list of every size you would need of PVC piping, the connectors and the size you need, and how to assemble this from scratch. Obviously, there are many ways to do and build a baby gym like this, but this just happens to be one that we provide families. Obviously, this isn't an endorsement for any particular type or brand, and Lurie is uses this as just a resource for family, but does not endorse that you need to make it this way or the person who supplies it. But this is a good example of the different techniques that can be used. Parents and individuals who want to implement more of a standing regimen for daily standing practice and overall strengthening have also built parallel bars using PVC piping. So there's a lot of options that can be pulled from homemade materials that we can easily find at a Lowe's or Home Depot, for instance. So these are some of the references that I've used today. I wanted to make sure, especially since I started late, that we have time for any questions that you may have or things that you still feel you have questions regarding exercise implementation or any of the recommendations from the standard of care for strengthening, stretching, and aerobic exercise.
Thank you so much, Dr. Hoffman. As Dr. Hoffman said, we'd like to open it up for questions now. Just a reminder, you can use the chat box to enter your questions. So it looks like we do have one question. Somebody's a little bit concerned about the illustration using the hammer. So yes. Wondering if maybe a kitchen dish brush or a ball and a sock could also work for that exercise.
Yes, it's basically that is just to show a certain weight that we could use versus it also gives good counter resistance for supination and pronation. That's why some people like the hammer, but that's also where you could use the assisted grip as well for those to hold on to soup cans or small dumbbells. You do not need to use the hammer. It's just a definite thing we utilize in therapy, but it's not age appropriate for everyone. So yes.
Perfect. Thank you. We also had a question about receiving a copy of the slides. This presentation is being recorded and will be available on demand on the MDA website later. So you can go back and look at that later. And somebody says, with my PT, we also do blood flow restriction. I really like the results. Is there any input on that?
Actually, no, because I don't. Can you offer any more explanation as to what the blood flow constriction entails? Sorry, I'm not familiar with that one. At least I haven't heard of it phrased that way. So maybe I do know about it and I just don't know that it's phrased that way. I'm very sorry.
Okay, we'll see if we get more information on that one.
Okay, sorry about that.
That's okay. Oh, it's using an arm or leg cuff to restrict blood flow.
As general principles, I've never implemented that. I don't like to restrict blood flow at all, usually when I'm exercising, but and I can't think of necessarily a time where I would want it. Is it specific to a certain exercise or is there a benefit you've noticed from doing that?
Looks like the follow-up says that they use an arm or leg cuff to restrict blood flow and then perform exercises.
No, I don't personally recommend that, but obviously if you're working under the supervision of a therapist or a trained healthcare professional, I'm not about to make recommendations that you should not do that. So as long as something is deemed safe and appropriate and it's working for you, go right ahead. I like to ensure that there is adequate blood flow to the muscle due to just basic physiology and safety. So we want to keep that muscle oxygenated and healthy.
Okay. We have a question about, is there too much exercise? I do 7 days a week, 2 to 3 hours per day.
Wow, I am very impressed. That is dedication, and I wish I could do that. Well, maybe not as much, but um, I think that's very individualized for everyone. It sounds like you are obviously someone who has regularly made exercise a lifelong habit and commitment in your daily schedule. So I feel like if you aren't finding that concern for overexertion, that a lot of times these are where we use the rate of perceived exertion and we monitor how we feel. So if you were, for instance, leading up to moderate to vigorous activity and you found that you really worked hard that day, but then you could not complete any other activities the rest of the day, things that you would do in your normal daily activities, that's a sign you did too much. Or if your soreness and fatigue and signs of overexertion carry over the next day, then that's also a sign that we need to cut back anything that we just increased in terms of reps or duration for any various strengthening aerobic programs. But it definitely is highly individualized, and I think it says a lot for people who have maintained a consistent exercise regimen. And for those just starting, you can work up to find your adequate fit.
Perfect. Thank you. Um, there's a question about, is there an assistive device you can recommend for opening cans or pickle jars?
Oh, that's a very good question. I want to say, I don't know any specific names, and my OT colleagues would probably be mad at me right now, but I want to say there's assisted grippers, but I don't know if you need something more than just an assisted grip. So though I'm thinking of those latex-free rubber ones that you can put on to help enhance your contact and grip on the object you're trying to open. But if it's for actual weakness and strength, that I am not sure of. So I can definitely find out for you, but I am not sure of a particular type, brand, or make for something like that.
Okay. Looks like, oh, we just got another one. How do you know when it's okay to exercise versus causing harm to bones due to muscle atrophy?
I think that has a few good points in that question. So that is a very good question. If you're just starting out an exercise program and you want to initiate one and you aren't followed by a multidisciplinary care or team setting, I highly recommend you go in for an annual checkup or physical. The multidisciplinary care setting offers typically an orthopedic or bone health specialist. They make sure if you have any ongoing cardiac, pulmonary, or orthopedic issues or concerns, that those are addressed. Some individuals who, one example is if they were hospitalized for a long time and become very deconditioned. You want to make sure that you slowly start working your way back up. You aren't going to be able to resume an exercise routine that you may have been doing daily before you had a setback, either health-wise or prolonged immobilization. Unfortunately, we lose some of the endurance and or ability to maintain our current level of function when setbacks like that happen. So, but if you were at that level with good, hard, consistent work, with proper parameters increasing for our progressions, you can get back to where you were. But I definitely visit your physician, whether it be primary care or a multidisciplinary team site, to ensure that you're being safe and that we aren't at risk for fracture or falls.
Okay, great. Thank you. Any feedback on getting KFOs approved? I use a chair and straight up denial as I say I need to be ambulatory for approval. My neurologist did peer-to-peer and still denied.
So we have a few of the individuals I treat are not, I think I need to ask you a few more questions, but are not deemed community ambulators in the sense that that isn't their efficient mode for mobility. But for, like I mentioned, for sitters who want to incorporate mobility devices as part of their exercise routine, it is a very challenging activity that increases their heart rate and counts as exercise. We have had them approved. We just have to illustrate and demonstrate clearly for the insurance companies that we are focusing on increasing balance and stability. One, you need certain things like that already just to start those trials. But some people work up to neomobilizers while they're waiting to get approved or have their KAFOs fabricated. So we have 2 or 3 individuals that use these for aerobic capabilities with walking. So it definitely isn't the most efficient mobility for them to use. They use manual wheelchairs, but they definitely use this, and it is a very strenuous workout for them when they're trying to increase their distance and time it takes to travel that distance. But as for denials, I do know people are getting denied for those, and I don't know if there's a magic statement to put down. But if you can demonstrate the qualities you do have for stability at the trunk and adequate core musculature needed to be able to shift weight and whatnot, and that this will help and continue to maintain and improve strength, stability, and overall function while ambulating, that would be the best start. I'm sorry that you're not getting approved for those. They could also incorporate an item saying that this will allow hands-free activities. So instead of holding onto a walker or a gait trainer, that a lot of individuals use these KFOs or ischial weight-bearing KFOs to help free up their upper extremities so they can do upright activities and utilize their hands.
Great information. Thank you. Looks like we've got one more question that has come in. Any thoughts on using mestinone? It seems to provide me more endurance in modest amounts. I don't know if I pronounced that correctly.
You might have. I pronounce it mestinon, but that does not mean I'm ever right about pronunciation. So I could be wrong. Yes, I think one of the physicians could speak to this more eloquently than I can, but we do have individuals who I've seen individuals with different neuromuscular disorders taking mestinon and having improved ability to function, to maintain the current level of function longer and throughout the day. But everyone's individualized and different with how their body responds to this and how long it's able to either make an impact positive. So some people are required to take it more than one time a day to maintain that effect or feeling of strength or endurance or limiting fatigue. So I can't say that I have a lot of patients currently taking this. I know they're looking at a bunch of different options and clinical trials coming up for things, but every person has a different response. But I have heard positive things so far.
Great. Thank you. I don't see any more questions. Oh, one more.
Oh.
Are there specific exercises that would be helpful for people who would be going through a significant medical procedure, for example, going through labor, that could help limit deconditioning due to that?
Yes, that would be one if you are thinking of, you have a specific procedure coming up and you want to make sure, such as bony procedures and different things where we know you're going, if you're a supported stander and you're going to be off your feet, we want to make sure that your ability to transition complete sit to stands is still intact and maintained while you're going through this recovery phase. So your physical therapist or a trainer who specializes or has experience working with individuals with SMA can definitely provide guidance specific to the procedure that's coming up, based on the evaluation and their findings of areas of weakness and what we need to maintain or what will be impacted by the said procedure. So it's definitely something that's worthwhile because it can help you get to the best potential ability of level of endurance and strength needed, because we know we're going to be impacted in a somewhat negative manner from the procedure just due to recovery time. So yes, if you can manage to reach out to a professional like a PT or a personal trainer that's qualified that can help you set up a specific program, that would be fabulous. And I think it would have many benefits.
Sounds great. All right, now I don't see any more questions that have come in. So this has been a great session with some wonderful information. Thank you again, Dr. Hoffman, for sharing your time and expertise with our community today.
Thank you for having me.